and a warm welcome. And I really thank Team Clearnet for organizing this particular webinar, which is very, very essential. Something that we don't really talk about. There's a um, lot of misinformation around Alzheimer's. We don't really talk about that. I'm really, really happy to have a panel with esteemed people from all disciplines, psychiatry, neurology, clinical psychology, to be part of this panel. Before we proceed, I'll speak a little bit about Therapeel. Therapeel is an online mental health platform. The website is www.therapeel.in. And at Therapeel, we want to make psychotherapy accessible and affordable. It's just like what we say, therapy is just one click away. We are trying to make that. And I'm very happy to have a wonderful team of clinical psychologists at Therapeel, mostly from NIMHANS, IPAS, and now coming to today's panel, just 1 second. Batul, will it be possible to...
Done, ma'am. Done.
Thank you. Coming to today's panel, I'm very lucky to have a wonderful set of panelists, and let me take this opportunity to introduce them one by one. We have Dr. Debanjan Banerjee. Dr. Banerjee is the consultant geriatric psychiatrist, Apollo Multispeciality Hospital, Kolkata, with 5 years plus experience. His research interests include dignity and human rights in older people and people with dementia, social psychiatry, psychosexual health, and qualitative research. He actively works in the section of Old Age Psychiatry WPA and International Psychogeriatric Association. He is also the Deputy Editor-in-Chief, Journal of Psychosexual Health, and Associate Editor, Journal of Alzheimer's Disease, and has over 100 plus index publication and 20 chapters to his credit. He writes for public awareness and several dailies and columns. So who better than Dr. Debanjan Banerjee talk on World Alzheimer's Day? We are also proud to have Dr. Advait Kulkarni. Dr. Advait Kulkarni is consultant neurologist trained from the prestigious Neurology Institute, NIMHANS, Bangalore, with more than 12 years of experience in neurology. He's a founder of HSR Neuro Clinic, Bangalore, and works as a visiting consultant in Manipal Hospital, Sajapur Road, and Narayana Multispeciality Hospital, HSR Layout, Bangalore. He has 8 years of intensive clinical teaching and training experience to neurology residents, registrars, and trainees at various prestigious hospitals. Thank you, Dr. Advait, for joining the panel today. We also have Dr. Raghavendra. Dr. Raghavendra, he will be joining. You will be able to see him very soon. He's driving right now. So I'll still introduce him. Dr. Raghavendra has a vast and multidimensional experience of more than 11 years in treating child and adolescent psychiatric conditions, all acquired at various prestigious institutes of India. He has been the first rank holder of the national level exams for NIMHANS, the first child psychiatrist in India to become qualified child rights advocate after finishing his school in child rights law. He's one of the very few child and adolescent psychiatrists in the nation who is skilled in both pharmacological as well as psychological therapies. He's a consultant child and adolescent psychiatrist at prestigious Aster Group of Hospitals and Renvo Group of Hospitals, Bengaluru, and is also a visiting child and adolescent psychiatrist in Indira Gandhi Institute of Child Health. Welcome, Dr. Raghavendra.
Hi, Ananya. I joined back. I joined.
Hi. Glad to have you with us today. We also have Ms. Pratibha Meena. Pratibha Meena is a consultant clinical psychologist at Therapeel. She has completed her MPhil from NIMHANS and is currently pursuing her PhD from NIMHANS. She's a clinical psychologist trained in psychological assessments and interventions for individuals in all age groups as well as couples and families. She's pursuing her PhD in neuropsychology from NIMHANS and has an extensive experience of 5+ years in working with neurological and neurosurgical conditions and clinical teaching. Her work involves rehabilitating individual patients, educating caregivers, and addressing their concern. She takes an eclectic and holistic approach in psychological interventions. So now that we know that such an esteemed panel that we have, it's time for us to start our discussion on the occasion of World Alzheimer's Day. I'll probably start with understanding the disease better, the signs and symptoms. So my first question is for Dr. Advait. If you can let us know a little bit about, how do we define Alzheimer's disease? What are some of the terms that we need to know? What are the signs and symptoms?
Thank you, Ananya and ClearNet for this opportunity. As we know, Alzheimer's disease is most common dementia beyond 65 years of aged people. And dementia means progressive neurological disorder, which mainly involves memory, also can involve behavior and other parts of the brain, other functions of the brain. And every 5 years, the incidence of Alzheimer's disease doubles beyond 65 years. So, and it is if you really see, it's a devastating condition where a person keeps on forgetting. Initially, it affects the recent memory, that is the recent events. The patient might repeat the same questions, ask the same questions. Patient might misplace the objects and forget where he has kept the objects. Increasingly, there is a need to rely on memory aids. Like if before the gentleman was able to go to the grocery store without a list, now he will make more and more lists. He will make more and more notes in the mobile phone to remember his ATM pin or mobile number, and kind of passwords and all that. Sometimes there is a difficulty in navigating through familiar locations, which is called visuospatial disorientation. A person may get lost, like he has gone out and he's lost. He doesn't know how to go back in a familiar position, a familiar temple or a familiar shop nearby. He might have difficulty in remembering the rules of favorite games, organizing grocery lists. So there are a whole lot of symptoms which affect memory. Also, the symptoms also affect word finding difficulties, like patient will not be able to recall the words. There will be difficulties in organization and planning. And later on, there can be confusion with time and place, trouble in joining the conversation. In the middle of conversation, he or she may just forget what he was speaking. And later on, there can be severe symptoms as well. Another important thing is the behavioral aspect of it, where a patient may forget, may feel very apathetic. He will not have interest in conversation, may not take so much interest in reading, writing, seeing TV, mingling with people. There may be mood disorders, personality changes, behavioral changes. This is what we are talking about Alzheimer's disease. Before Alzheimer's disease developed, there can be something called minimum cognitive impairment, which is a memory problem, which is slightly more than expected for age. So all the patients of MCI do not progress to get Alzheimer's disease. But if somebody is having MCI, we always need to be watchful. And if we are able to prevent this MCI, minimal cognitive impairment, maybe we'll be able to prevent Alzheimer's disease. And another important thing, what we see in young individuals is a subjective cognitive impairment. Typically, a young patient comes to our clinic, typically 35 to 25-year-old, and says, "Doctor, I am forgetting things. Main bhul raha hu." So typically they say, "I forget words, I forget names." And that can happen in anxiety as well. So it's a subjective symptom where objectively we do not find any abnormality. So I think
your voice was breaking a bit. Could you please repeat the last?
Yeah, so the last thing I said was about subjective cognitive impairment. And I said, now we can go ahead.
Thank you. Thank you for starting off the discussion. And I think some of the things that you definitely highlighted was it's highlighting towards memory disturbances. And you also talked about mild cognitive disturbances. Usually we have this question, often people ask us, like particularly layperson, that, okay, is dementia and Alzheimer's the same thing or are they different? How is Parkinson's different from dementia and Alzheimer's? Could you shed a little light on that as well?
Yeah, so see, dementia is any syndrome where there is progressive impairment in memory. Alzheimer's is one of the most common causes of dementia. Other dementia, so it contributes to about 60 to 80% of dementias. And about 10 to 40% of dementias, they can be vascular dementias, which happen because of the multiple small blockages in the brain, mainly the periphery and the of the brain, where a person might face problems in multiple domains of memory and behavior, but it is not as badly progressive as Alzheimer's. So one is the Alzheimer's, then is the vascular dementia. Then we have a rare dementia called frontotemporal dementia, which typically involves the frontal part of the brain, which is associated with the planning, execution, and behavior. So these patients have a whole lot of bad behavioral problems, or a subtype of frontotemporal may have language disturbance where they are not able to speak properly, and gradually the speech deteriorates so that there is complete anarthria, where a patient may not be able to talk or would not talk anything. Another rare dementia would be a dementia with Lewy bodies, which typically presents with florid psychiatric symptoms, which is like visual hallucinations, delusions, and again the involvement of the recent memory and visuospatial disorientation. Other dementias would be dementia associated with Parkinson's disease, various kinds of Parkinsonian syndromes. These are all degenerative kind of dementias. But when we look at treatable dementias, they can happen because of hypothyroid, that is disturbances in the thyroid hormone, vitamin B12 deficiencies, certain brain tumors, temperature hydrocephalus, where there is a water accumulation in the brain and which can cause memory problems as well as walking issues in the patient. Also certain infections like HIV or herpes infection in the brain, when it gets cured, that can also lead to dementia. So we always look at whether the dementia is treatable or it is not treatable.
Thank you for clarifying that. So what I understand is it's quite a progressive degeneration. So when it starts, it's almost like it's very difficult to differentiate. So my next question is for Dr. Debanjan. If you could if you could explain, particularly keeping in mind somebody who's not aware of the neurological terms for the lay person, what are the typical signs and symptoms one should look out for? When should one go out for a checkup? And how long should they wait, or should they wait at all? Because some of the things we often say, oh, this is for old age. So how do we basically decide when to go for a checkup?
Yeah, thank you, Ananya. I think I'm audible, right? Yeah.
Yes.
The common question we all ask still now. Yeah. So thanks, Clarinet. And the best part of it is meeting up a lot of people after a long time. So it's great to be on the same panel with Ananya, Advait, Pratibha, and Dr. Raghavendra. So a happy reunion once again. I think I totally agree with Ananya on this, that this is a narrative which we very less commonly discuss about Alzheimer's. And especially, this year, the theme, as you mentioned, as Batul mentioned, is to know dementia and Alzheimer's, because as Dr. Advai stressed on it, it's the commonest form of dementia. One of the common problems that we face, and based on, just to take an extension of your question, the Dementia India report that was released in 2018 kind of showed that only 1 in 10 cases are diagnosed, or they really come to a treatment. Now, just in sheer numbers, imagine how concerning that can be. One of the major reasons that you pointed out was that, its memory loss is normalized as a part of age. People, the social demands, the family expectations from a senior citizen kind of tends to get very low. So imagine, when we think about our mothers, grandmothers after a certain age, or even, fathers, grandfathers for that matter, after retirement, be it any gender, they are expected to be taken care of by family without much demands of work. So the threshold at which Alzheimer's or dementia gets diagnosed depends a lot on the family's understanding, the social norms as to what is expected out of the particular person, and also whether behavioral problems set in first or not. practically, when Advait was mentioning, it just struck me that, there may be years before a person gets brought to us because of memory problems. Whereas if the person starts to go out of the house, get lost, wander, get agitated, the family members probably bring him or her faster, because that kind of is a striking point. Now, to come back to your question, how do we understand? I think it depends a lot on what a typical day of a person is or was, what a person is expected to do. A farmer who has spent his entire life in a farm with bullocks, with, farming, with calculating the harvest, will have a very different kind of demand of work, rather than, let's say, a professor who has retired and is not able to do mathematical calculations. So it all depends on how it's coming to the forefront, how people are coming to realize about it. One good thing will be to understand the earliest parts of it, forgetting names, misplacing things, not able to navigate in an unfamiliar situation, suddenly not able to recall what a particular thing is, suddenly getting lost amidst conversation. Sometimes there is a decrease in interest to socialize, because the person somewhere realizes that I am not able to do it like I was doing it before. Now, as Advait mentioned, there is a pre-dementia stage. I think that becomes utmost importance, the mild cognitive impairment. Now, even we talk about a stage in today's research where we even go before that. We talk about a pre-dementia stage altogether. Now, even if the person is able to do the same thing, but he or she has to put in much more effort into it, I think that should be a warning sign. Irrespective of age, if after 50 somebody is forgetting, somebody is not able to recall things spontaneously, there is a problem in navigation, there is a problem in behavior. Let's say a person who has been very introvert, has been very kind of peace-loving person all throughout, suddenly tends to be very agitated. On the other hand, somebody who is very extrovert, has always liked to socialize, mingle with people, go to parties, talk to people, suddenly turns to become very inward, restricted to life, isolated. I think this becomes extremely important for elders who are staying alone, who have paid caregivers, who are staying in institutions, in assisted living facilities, because still we kind of take this message to the caregivers, to the people who look after them, to trained nurses, people at old age homes, the staff there. I think we'll be missing signs. And there is a very common dictum that is mentioned by the ADI, the Alzheimer's Disease International. It's never too early and it's never too late to prevent dementia. So doesn't matter you are detecting at 50, you're detecting at 70. If you feel there is a problem, first take professional help. General physicians, psychiatrists, neurologists, psychologists, doesn't matter. Take to a person who is there in proximity, and if needed, that concerned person will direct you to the appropriate professional. The last thing to answer your question is, there are times when there is an ambiguity. So let's say sometimes the person is doing fine, sometimes the person isn't. I think we should really understand here that after 50 or 60 years, the two commonest problems are, on one hand, dementia, commonest being Alzheimer's, what we are talking about today. The second is depression in old age, and both have several intersections. So for a caregiver, from a layman's point of view, forgetfulness can also come from depression. It can come from loneliness. It can come from grief. It has repeatedly come to people who have lost younger generations and suffered from existential crisis during COVID. It has come to people who were deprived of their basic amenities, during COVID times. So the lack of autonomy, the restriction of mobility, frailty in general can also bring in forgetfulness. So not every forgetfulness is Alzheimer's. But before you understand that, it's better to take to a person who probably will clear it out for you. And as I said, I'll repeat it, it's never too early, it's never too late. The earlier we detect, the lesser we reduce the burden of dementia in community.
Right. I think that's a great take back when we say that it's never too early and never too late, because one of the things that we usually see is we wait for a very long time, and we tend to minimize some of the symptoms. We just say, oh, it's nothing. And I'm glad that you brought up the idea of geriatric depression, which is also something we hardly talk about. But the presentation of geriatric depression is very different from any other form of, in like adult depression or childhood depression. And that it can have overlapping symptoms is a very important thing for us to remember. There's one more clarity that I would seek at this point of time, since you were mentioning about, there's a lot of things about change in how the person used to be and now how is doing, particularly behavioral changes and difficulty in navigation. Uh, we have also seen, particularly post-COVID, many people having difficulty remembering names only. Like maybe the other part, like they're being able to recall everything, but they're having difficulty recalling names. And we also see a tendency in these people not to go for a checkup saying, oh, this is a post-COVID syndrome, this is brain fogging based on what they're reading. What is your take on that?
Yeah, thanks, Ananya, for bringing that out. In fact, we do have a lot of people coming to us now. I'm not sure if I can call it post-COVID. I'll be happy to call that. I think the pandemic is still going on, but at least after this phase, the two phases of lockdown, and after the third wave, a lot of them come to us now telling that, we thought it was something related to post-COVID, but now I'm seeing that, probably things are kind of taking a greater toll. I think Dr. Advait and Dr. Raghavendra will agree on me on this, that over the last 1 year, we have actually seen a lot of senior citizens who had COVID infection or who were totally isolated during the lockdown present to us with a lot of memory problems. Those who already had existing, let's say, MCI, pre-dementia, Alzheimer's, many of them have kind of got it accelerated. Because what we have to understand here is, the very reason why we have a multi-dimensional, multidisciplinary team here is because Alzheimer's is not just about neurons decaying or abnormal protein deposits in certain parts of the brain. It has a lot to do with lifestyle, the metabolic risk factors, that is the diabetes, hypertension, obesity, degree of education, literacy, number of languages, how much you're active before post-retirement. So basically, when people ask me that when do you really start preventing Alzheimer's, it is from the time when the baby is born. It cannot be earlier than that. Because, it's not that you go at 60, 65 years and then you start preventing Alzheimer's. That doesn't happen. It rather starts at 20, 30, 40 years. Now, it's important to understand that a lot of us, younger or older people, have had slight problems in recalling, problems in focusing attention, driving. Many may tell you that, I am reading through a line, but it seems as if nothing has got registered in my head. Now, that is probably the earliest sign of brain fog. But I think the ideal timeline would be that even if post 3 months after a recovery from a symptomatic COVID infection, especially if somebody is above 50 years or somebody who had memory problems in the past, if you feel that things are not really getting back to normal or things are worsening, it is always better to seek professional help. Because we don't know. See, it may not be Alzheimer's, but again, the differentiation is always not possible at the level of home. In fact, even when we diagnose, be it based on the clinical criteria, we always have to take independent assessment of the person, the caregiver's perspective, supplemented with, the necessary assessment tools. So only then can we comment on the complete picture of the memory. Yeah.
Thank you. Thank you for highlighting that, Dr. Debanjan. And like you said, and Dr. Advait also mentioned that the Alzheimer's is not just like what we call the disease of the neurons. It is something much more that's dependent on many other factors. So my next question is for Pratibha. She is a clinical psychologist from Therapy. And Pratibha, if you could highlight some of the psychological factors associated with Alzheimer's. I think you're on mute, Pratibha. You're on mute. Can you unmute yourself, please?
Yeah. Thank you, Ananya. And I think a lot of has been covered by Dr. Debanjan in what all goes behind Alzheimer's, not only neurologically, but also psychologically, behaviorally, emotionally. And this, when there is Alzheimer's, it does not only affect one person, it does not only affect the patient himself or herself, but it also affects the family as a whole unit. So talking about the individual patient, there are a lot of psychological, or before that, because it's a disease of the brain, or it's a cluster of symptoms. So the first signs and symptoms that we see are more of neuropsychological or cognitive in nature, like it has been mentioned that recent memory, working memory, the differentiation of long-term memory and short-term memory, working memory, those kind of uh, different aspects of memory. Then about attention, which is very easy to ignore, that okay, it's just I haven't slept well, or maybe I haven't eaten well, or some or the other reason to just say that I'm not able to focus, or a patient may say, oh, what did you say, I didn't get that. So these are smaller things where the symptoms may start from. And going on to higher order cognitions, like decision making, planning, impulse control, which might seem as it actually manifests as a behavioral issue, but at the root of it, it is a set shifting issue, or that kind of impulse control, response inhibition, those kind of neuropsychological uh, functions. And it also, there are stages of dementia, that first it is in the mild stage and the patient may not have insight into what he has, and he might have smaller issues or smaller difficulties in his day-to-day life, and he may not be very well aware of them. And these smaller issues here and there, first he starts getting frustrated with them, that where did I keep my keys, I just kept them here, why do people keep taking my things, why do you not understand? So that kind of, it manifests like that, but it is a cognitive issue. And then when it deteriorates more and there is moderate and then there is severe dementia, there are bigger issues. The insight is not always there, but it's always not there as well. There may be some sort of insight that, okay, there is something changing within me, or I was able to do these things. Something is maybe wrong. And that may lead to depression. Like Dr. Dimanjan said, there may be depression of old age, and there may be depression associated with Alzheimer's. It may lead to anxiety. How will I go out? How will I maintain myself? How will I manage? Maybe I'll forget something. Maybe I'll forget the way. How will I cross the road? If a patient finds himself in a strange environment or an unfamiliar environment, and suddenly he realizes that I'm not supposed to be here, and then he realizes that maybe something is wrong, and that might lead to anxiety issues. Uh, More organically, there may be apathy, like Dr. Advait said, because of the decay of the neurons, the degeneration itself. There may be paranoia, this is leading from small things, like I keep my things here, you people, somebody is keeping track, somebody doesn't, someone wants to hurt me, harm me. That kind of things can manifest as paranoia. And it may be organic, that actually there is, that can be treated with maybe antipsychotics, maybe the doctors here can shed light on that, but it can also be a manifestation of anxiety, in that sense that it comes out as paranoia. So this is about individual difficulties, but also at the same time, the caregiver burden is a huge problem, issue, whatever you call it, when you are caring for a person with Alzheimer's dementia, it is a huge responsibility, and slowly there may be burnout setting in. There may be frustration setting in. Where there was a loving relationship, there might be so much frustration that, it's unfortunate, but you see a lot of um, older people on the road with no family to call their own because they have been abandoned. The family just couldn't take care of them. So caregiver burden is also a huge issue. It may lead to depression. It may lead to anxiety in the caregiver themselves. It may lead to a lot of emotion dysregulation. It may lead to physical violence. So on and so forth. Yeah.
Right, right. Thank you, Pratibha, for sharing all these symptoms and details. And I think the other one that Dr. Advait also highlighted about visual hallucinations, that is also, I think, yes.
Ananya, sorry if I may just add just one thing to
Yes.
what Pratibha said. I think what she mentioned in the end is of extreme importance, that the caregiver stress. We all talk about elder abuse. We talk about the problems that happen in seniors. But I think here is a very important point. Because of the misunderstanding, the misinformation, the myths related to Alzheimer's, many people tend to believe that probably the sudden change in behavior of a senior citizen is intentional. And because of this, misconstruing this fact, many caregivers, even with their honest intention, sometimes resort to covert abuse. So, it's not always intentional, but in fact, caregiver burnout and caregiver stress in dementia is one of the very common and concerning risk factors for abuse, especially when it is staff in an old age home who do not have sufficient training to understand this. And so many times when we have gone for visits, we hear this, that, for long, I just thought that he or she is doing it intentionally or to gain something. And this is very harmful because many times they receive unnecessary medicine, isolation, restraint, and it's a very, very sad story. So thanks, Pratibha, for just bringing this out.
And thank you, Dr. Devanjan and Pratibha, for highlighting this aspect of caregiver stress. And I think this aspect of thinking that it is intentional, it is something that needs to be highlighted. And whatever all three of you till now said, almost is screaming for the need for awareness. Awareness not only among the caregivers, but also for the staff in any institution. How to identify, how to respond, how to address. So it's almost screaming the need for knowing what it can be and how to respond to that, because probably a lot of this quote unquote covert abuse can be because of ignorance more than anything else. So you also mentioned about some of the misconceptions around dementia. So I think one of the other conception, I don't know whether it's a misconception, but a conception around dementia is that it's only particularly Alzheimer's, it only happens with people of the old age group. Dr. Raghavendra, you have seen clients across all age groups. You've seen children and adults and people from the old age group. So if you can tell us, is it true that it only happens with people of the post 60, or it also happens earlier?
Yeah, before I get into the discussion, I would apologize for the delay. Thanks to the Bangalore traffic, I got delayed by some five minutes. And I would thank Ananya and Clarinet for choosing me as a panelist. And it's a kind of a peculiar choice, a child psychiatrist in a geriatric geriatric expert panel. But it does actually make sense because I will bring about certain relevant things and we will discuss about certain things. And it is, I would also, like Devanjan pointed out, my good friend Devanjan, it's a reunion of sorts. Ananya, Devanjan, Advait, and Pratibha. So all of us, we are meeting for last discussion we had Hemendra on board, and so it's again a nice homecoming, so to say. And Obviously, a lot has been discussed by the doyens in their field, Dr. Debanjan and Dr. Advait. I will not I'll not be reiterating what they have discussed. But one thing I would want to say here is, see, um, childhood ADHD itself is a characteristic illness where there is forgetfulness, if you remember, right? Childhood ADHD, classically, child does not register whatever is, uh, and it's neurodevelopmental. So, brain is developing, uh, a growing brain, so to say, and Alzheimer is degenerating. So it's in a like a senile, it's like end of life, so to say, early, terminal or plus 60s. So where does this merge? Where to reconcile this? That is where people might wonder, and that is what is Ananya is asking about. But one very peculiar thing what might be noticed is, and one very good area for research, um, kids with Down syndrome. Very classically, they manifest symptoms of Down syndrome is an illness which has a lot of neurodevelopmental symptoms, but they manifest neurodegenerative symptoms very early in life. So one very classic symptoms. So we see several kids like that, and if you follow them up, by 25, 30 itself, they start showing signs of neurodegeneration. So that is one area where we see. And one more thing which came up. No, so like today morning I saw one kid. He had terminal cancer, Hodgkin's lymphoma, and because of chemotherapy, and he had melancholic depression, and because of chemotherapy, possibly there was some degenerative changes which might have happened in his brain. So he had some symptoms of dementia plus pseudo dementia. So it was very difficult to assess him. So there are some interfaces which happen. So we don't know whether it was, and he had a well-developed brain. He was functioning pretty well before the illness started and the chemotherapy started. So we don't know whether it was a degenerative illness which started after the chemotherapy started. So, like to answer your question, Ananya. So classically, they say neurodegeneration starts after 65. It doesn't have to be like that, right? So, and I see many people nowadays, especially after the internet GAN is very easily available. Young people come with since I'm a childhood illness expert, they come to me directly and say, "Doctor, I have ADHD." They don't even they ask for a certificate. Doctor, I have ADHD and I want to present a certificate at my college. They're 25 and they say they are sold out to that idea that they have ADHD, about forgetfulness, about everything. They'll tell, I have this. But if you look back, they might have something else. So the point I'm trying to tell here is they need detailed assessment, and there might be several other illnesses also which might manifest in this thing. So this is one thing. And there are several other neurological conditions, which I mean, loosely termed as childhood dementias, which are called like lysosomal storage, where the brain starts degenerating very early, like Pelizaeus Merzbacher disorders. Basically, the brain starts degenerating very soon because of some inborn errors of metabolism, and so the kids start showing whatever Advait said, no, forgetfulness and visuospatial disorientation, several other symptoms which Advait mentioned early on in the beginning of the discussion. They start showing very soon, like say by age 10, age 12, age 13, 15, they start showing that very soon. But they will have several other symptoms, physical signs and neurological signs also. So this is why I was very happy when they chose me to be on the panel. Initially, I thought maybe should I accept the invitation or should I refuse? But I thought, being a child rights advocate, I thought I should actually choose this chance, and I never let go of a chance to talk for children. So this is what I say. Although the conditions which I spoke about, the childhood dementia, childhood degenerative disorders, so to say. They are a bit rare, but they do cause these kind of symptoms, and they have to be assessed, and very rare. Especially, they are more common in European setup. They're much more common, especially in the Mediterranean region and the European region. But even in India also they are common, and unfortunately they are not treated, and there are no medications for that. So they have to be picked early. Once picked early, reducing the morbidity is also much more possible. So yeah.
Thank you, Dr. Raghavendra. First of all, thank you for accepting the invitation. We really thought about, why we would like to include you in the panel, and your expertise here is very much valued. We really wanted to bring that entire range, and I'm really glad and grateful that you accepted the invitation.
Thank you
And
so much.
yes, you're rightly saying that it is a reunion of a sort. It's very nice to see everyone and meet, because we don't get to meet otherwise. It's platforms like this that we end up meeting and talking. So, like you rightly highlighted some of the aspects of how some symptoms can be overlapping. It's very difficult to really differentiate. Dr. Advait, Dr. Debanjan, would you like to add anything to that?
Actually, it's really nice to hear Dr. Raghavendra and all of you, because even in our setup, we see patients who have, we don't know whether they really have pseudodementia, but they end up having organic brain disease. So I think one needs to be vigilant always. As a clinician, as a neurologist or psychiatrist, we always want to label certain aspects, but it's always better to evaluate, as Dr. Raghavendra said, rather than just assuming it as pseudo dementia.
Right. Thank you, Dr. Advait. So while yes, Dr. Debanjan.
So I think just on a different note, Dr. Raghavendra was asking as to, I think you have a very, very important place here as a child psychiatrist. I just said that the prevention of Alzheimer's starts when a person is born. So, I think in terms of preventive aspects, we always talk about the earlier we can go back to, the better it is. In fact, I think just a few days back, we were discussing the Lancet report on Alzheimer's that came out in 2020. It's a landmark article. And it's very surprising, and should I say optimistic, to see that it mentions 40% of the total risk can actually be modified with the modifiable risk factors. And among that, out of the 12 risk factors, around 5 to 6 fall within the age group of 20 years. So, the level of education, literacy, how a child is usually kept active, whether the person is having the type of parenting, the type of socio-ecological atmosphere, I think it all makes a difference. And especially, I never leave a chance in any of the forums, because I specifically work in the area of human rights. So if we really have to advocate for autonomy of older people, especially when they cannot speak for themselves when they're having the condition of Alzheimer's, I think it's important to start early. And it's not just, for research, we use a very arbitrary cutoff of 60, but all of us, especially in a country like India, where diabetes and hypertension are like endemics, we should really start looking at these conditions right from the time when it's 30, 35 plus. Especially if somebody crosses 40, I think the antenna should be open for any types of issues with memory. And, it's not just about memory, in fact, because I think a lot of stress is given to memory, especially in Alzheimer's, but it's also about wayfinding difficulty, language, forgetting, very common words, having problems with reading and writing, having problems with speaking, having grammatical errors when a person speaks, issues with behavior, and finally problems with what we call as many of you were pointing executive functions, which is basically how human beings have evolved: multitasking, reasoning, judgment, judging an appropriate social response based on the other person's behavior. So I think, as I told in our last panel discussion, Ananya, I'll be really happy if every single person, Batul will tell us later how many of them attended, but if every single person can at least inform one more person about whatever we're discussing, I think the awareness goes to the community, or else it stays among 6 of us. Yeah.
Ananya, you're on mute.
Absolutely. Sorry. Yeah, absolutely. I completely agree with the Banjan. And the idea for this panel also is to create the awareness that dementia, or Alzheimer's for that matter, should not be seen as a post-60 or post-65 disease. It should be seen like we have to understand how it is spread across the entire lifespan, and how every single factor, like I can see a question from Dr. Rahat, who is asking what nutritional supplements can help in decreasing progression of Alzheimer's. But I'll come to that question a little bit later. But I think what we are also seeing is that people are thinking about the various factors across the entire lifespan, cumulatively ultimately resulting in Alzheimer's and the presentation of Alzheimer's.
I wanted to add one more thing. Sorry to interrupt.
Yes.
Can I add?
Yes.
One more thing, what I've noticed though, sensory deprivation is one thing across age ranges, like starting from early life. See, if you notice, see, Abhimanyu learned to cross Chakravyuha when in mother's womb, when he was 7 months old, intragestational. So the senses start working at that age. And I am a child psychiatrist, and I start working with antenatal mothers also. And I noticed that sensory deprivation, especially during COVID, actually had a huge impact at that age. And mothers in depression and sensory deprivation has had a terrible impact. And I'm seeing those kids go into horrible symptoms of autism. Not autism, but symptoms which resemble autism. I wouldn't call that autism actually. And at the same time, at the other end of the spectrum, elderly people go rapidly accelerate into depression or dementia, or which overlap, which looks like depression and dementia, a mixture of both. So there is definitely an overlap. And there is definitely, that is where I said, no, I pounced on this opportunity to bring these things up. There is definitely, although there is a huge age chasm, it is definitely overlap, and there is a huge connection. And there is a saying in Kannada, as you grow older, you actually become like a baby. There's a saying in Kannada, and I don't know whether it's there in Hindi, I don't know, but I see that happen. Elders also start regressing, right? When 70s, 80s, they start behaving like they start seeking more attention. They start behaving right. I think all of you will agree, right? So exactly. So there are several things which actually we tend to lose some emotional regulation. We tend to lose some thinking faculty. We tend to lose and some release reflexes also. Neurologically also it correlates, right? The infantile reflexes start coming. So there is a lot of correlation which happens. So that is why I wanted to bring some parallels and tickle our gray cells and prevent our dementia onset also.
Absolutely. While you were saying, I was almost visualizing, it starts from the fetal position like this. And if you see the entire lifespan again, it's sort of they sort of stoop down after a particular age and they come back to that position. So almost that visual presentation came to my mind. So thanks for sharing that wonderful description. And Dr. Debanjan, you wanted to add something to that?
Just to add to that, I think when Dr. Raghavendra spoke about sensory deprivation, there is a very important thing that we tend to miss in seniors, at least in our country: hearing loss. It's a big thing. In fact, 70% of people will be coming without their hearing aid. They will not want to use the hearing aid. You will see the family literally shouting in their ears. And Pratibha, I'm sure you have faced a huge challenge with your neuropsychological assessment when this comes. In fact, half of the times I think the person is not able to understand what I'm telling, and then I realize that, not even 70% of that is reaching. Hearing loss is a very well-researched risk factor for dementia. And I think all those who are listening to us, it's mandatory to correct hearing loss as early as possible, because both visual and hearing loss, visual comes to forefront pretty early because it creates much more of disturbance. But hearing loss needs correction, because otherwise the progression of dementia is very, very fast. So just, I'm thankful that Dr. Raghavendra mentioned about sensory deprivation. So this is something which becomes very important in the seniors.
Right. So I think we are now sort of understanding that how so many factors are dependent on the progression of Alzheimer's. So it's not like one isolated disease and we have nothing to do. There's like a conglomeration of other factors which impact the progression of Alzheimer's. We were talking about some of the myths associated with Alzheimer's. Pratibha, would you like to speak about any other myths that you've come across during your practice? Because in society, we have certain perception and beliefs we hold about certain things. So would you like to shed light on any of the beliefs and myths?
So I think the one major, which all of us have spoken about time and again, is dementia is Alzheimer's and Alzheimer's is dementia. That is a myth, and that is not true. Alzheimer's is a classification. It's a subtype of dementia. There are different types of dementia, as it has already been discussed, and Alzheimer's is one of them. You can't just say that, okay. The switch or the flip side of it is also true, where you have some forgetting, and like I think Dr. Advait mentioned that even anxiety can cause forgetfulness, and some sensory overload and work burden, anything can cause forgetfulness, momentary lapses in memory, and that also should not be called dementia or Alzheimer's. But okay, I think a lot of how we perceive things and how we understand things start with language, and we have to be mindful of the language that we use or the things that we say. That okay, I'm forgetting. Oh my God, I'm getting demented. Even that's not a nice word to, like, how you don't, like, now people are understanding, okay, don't call somebody bipolar. You have bipolar, you are not bipolar. And similarly, demented is it's a very I don't know, it's an unfortunate term that people have just using it very loosely. So dementia does not equate Alzheimer's. And other thing, I think somebody mentioned about supplements. So there is a lot of, even in the West or even in Indian scenario, there is a lot of, that, okay, I think that's some herb, it's, I think Shank Pushpi or something it's called. And it's good for memory, it's good for, preventing dementia. And like in our scientific fraternity, till anything is, empirically evidence-based and all, we do not really can say that, okay, this is what prevents. And of course, there are a lot of things that are coming up. People are trying, some things are helping some people, but these are more of anecdotal anecdotes. And so these are also widespread myths that you can prevent Alzheimer's because you can have supplements. There are, like we discussed, there are a lot of factors, including genetics, including lifestyle, including your obesity even, and those kind of things. So there are a lot of factors. And that also is another myth, that it is hereditary. So there is some truth to it, that, okay, there is a genetic role in having Alzheimer's, but also it is not cut to cut, that, okay, because your parent had, you will also have. It's not so saying that because one of my parents or somebody had it, and the family I will also have. Maybe it increases your risk, but it's not the same thing. So I think those are some of the major myths. And then about patients or people with Alzheimer's disease, there is, like I spoke about physical violence that happens to them. There is also, people may call that, okay, he's aggressive. Now he's, you need to put these people in restraints. Or there is another one that now they're dependent. So there is, of course, a altered role or a loss of the role that the person played in the family that changes. Maybe somebody else has to shoulder that responsibility. But equating or just calling a Alzheimer's dementia diagnosis that, okay, now your life is done, now you'll be dependent, you should just be put in home, we will not be able to manage, there are children in home, we cannot trust you. So those kind of things. So there are a lot of nuances to it. It's not, nothing is cut to cut that, okay, this means this. So there, depending on the stage, depending on the issues that you have, depending on the treatment that you're getting, pharmacological and psychological. So it is, that brings me to the management. It's not uncurable. It is, of course, there is no cure as such, so to speak, but there are treatments that can slow down the cognitive decline, that can manage the behavioral issues, that can make the quality of life still can be maintained. It's not like you got this diagnosis and you're done. So there are a lot of myths, and that they are really so common that it may, because they are so common, it may just be construed as truth. So I think we really need to be careful about these things.
That's a very, very important thing to say, Pratibha, when you say they're so common, we almost take it as a truth because almost everyone is saying the same thing. And in this process, you also answered a few questions. You answered a question by Dr. Rahat about the supplements. You answered a question by Dr. Govind that can Alzheimer's be completely cured? And you responded to that. Dr. Sanjay, we'll come to your question in some time. But Dr. Debanjan, you had been working as a geriatric psychiatrist for a very long time. In your practice, how does these kind of myths come up? Do they at all come up, and do they interfere with the intervention treatment?
Yeah, I think myths are in general very, very prevalent about this particular condition. See, the problem is, as I started by mentioning, that the commonest myth is that aging is inevitably associated with forgetting. So a lot of times this prevents people from taking help. The second is that, a little bit of forgetfulness is okay, we can bear with that. So you don't really need medical attention or medical help. So unless, hell breaks out loose, unless somebody kind of becomes very agitated, has paranoia, suspiciousness of things like that, not sleeping at night, it's not normally, the person is not normally born. Now, what Pratibha was mentioning about supplements, we very recently, published a review in Intech Open specifically with nutritional supplements related to Alzheimer's. When we were actually reading up, I myself didn't know so much nutritional supplements exist, which work on cognition. There are products which are called nutraceuticals. It's a huge industry. If you open any traditional marketing forum online, you will get plenty of them. The very, very common thing everybody knows about is ginkgo biloba, ginseng extract, a very, very popular Ayurvedic and a plant known as Brahmi. Those who are Bengalis, us, I'm sure we have heard about Brenolia when we were young. So traditionally, these plants are told to boost memory, which is not untrue, of course. But then the problem is what we need to understand three things here. And I think we should clarify in a forum like this where a lot of people from various disciplines are there. One, there is no proven, research-based, evidence-based, licensed nutritional supplement for either MCI or Alzheimer's disease, period. So whatever you are trying, it may help, it may not. There have been some research with ginkgo biloba in MCI, but it has not been really shown to reduce the progression. Yes, it has been tried. We all try. But now the thing is like this, that many of these plant products, they have certain extracts which can interfere with the enzyme systems in our body, especially liver enzymes. So it is probably not advisable to use any of these supplements without consulting your doctor, because senior citizens, they tend to be in a lot of medicines for pressure, sugar, prostate, heart, cholesterol, stroke, a lot of stuff. So many of these supplements can cause a chaos with these systems. So many times when people come to us, it's a common practice in geriatrics to receive 6 prescriptions, and you will see that each prescription has one different supplement. So the person is on 6 supplements. Probably sometimes 3 of them are similar. Now, you cannot blame either side of the table, because many times in a busy practice, it's not possible for me to see what the other person has prescribed. But then it may be a worthwhile practice for each caregiver treating a person, looking after a person with Alzheimer's, to settle down all the medicines, see what medicines he or she is taking, and periodically review with a treating physician as to if all of them are really necessary. Because trust me, it's very easy for me to write or type 4, 5 pills and give. If I am to take 5 of them, I literally run away. And it's a challenge to give it to individuals who have Alzheimer's disease. So the less the medicines, the better it is. The last myth I want to talk about is, people tend to have this belief that you have dementia, you have Alzheimer's, you come to the doctor, you visit, you understand, you go back, you're done for life. That's not how it works. A very important component of treatment is review, going back and assessing, okay, these are the medicines that I have given, these are the lifestyle changes I've suggested. So whether these are actually working, how is the person after 3 months? Like any other non-communicable disease, dementia is a continuum. Alzheimer's is a continuum. So, of course, I'm using the word dementia and Alzheimer's interchangeably for the sake of discussion. But let me once again remind that Alzheimer's is a type of dementia, but all dementias are not Alzheimer's disease. So it happens on a continuum, it happens on a spectrum. What you see now may not be the same after 1 year, 2 years. It may not be same after 10 years. So what you see in the clinic is essentially a snapshot, not the complete picture. So just a request, if you are the caregiver of somebody, if you are looking after somebody, if you're a patient, if you know somebody who is a patient or a caregiver, please suggest that going to the professional for the first time is just the start of a long journey. And you need to revisit periodically to stay informed about what are the problems that are usual. Because if you have a challenge as a caregiver, it is important you discuss with the doctor. The caregivers are at a lot of immense challenges, stress, the entire process. So if you go to the physician, if you do not relay your challenges, it may not always, be heard. It may not always be solved. So it's important to periodically go, discuss, and also get an update about the medical and non-medical interventions that you can do to help your patient.
Thank you, Dr. Debanjan, Thank you, Dr. Debanjan, for highlighting this very important aspect of, I won't say always self-medication, but like you very honestly accepted that if I have to take so many medication, I'll think twice. So I think that fear and that hesitation is there in everyone, and they often sometimes tend to think that, I don't want to take so many medications. I don't want to take, I would like to go for the natural supplements. So thank you for clarifying that and for highlighting the fact that it is important for not only the patients, but also for the caregivers to have an honest conversation with the doctor, tell what their thoughts are, what their concerns are, and then decide what's the best way forward.
Yeah.
Dr. Advait, yes.
I wanted to add one thing. My
Yes.
experience with one patient, actually one of the patient's son on a follow-up appointment, he said that my father improved so much after he saw you. I was really amazed ki how can a dementia or Alzheimer's patient improve in 2 months so much? And then I remember after Dr. Debanjan said he was on 5 to 6 medications when he came to me. And unfortunately, the treating neurologist had started him on some SSRIs, some sleeping pills also. So once we reduced all those supplements and all these things, he actually started taking more interest in reading newspaper, communicating, and he improved. So that's a man-made trouble sometimes over medications and excess of tablets, and just reducing tablets will help a lot many times. Yes.
Right, right. So thank you again for reiterating the fact that it is not always like you take more medication and you'll be fine. Sometimes it is like the correct restrained use of medication that helps, and that can only be done when you're honest with your doctor and what you're taking, what you're not taking, what are your concerns, everything. Dr. Advait, could you also shed some light on the diagnosis and treatment part of what is
Yeah.
the typical line of thought? Yes.
Yeah, when typically a patient comes to us with memory complaints, as we have discussed in so much detail about, it can just not affect the recent memory, word finding difficulties, visuospatial disturbance, behavior, and a lot of aspects. So after taking a detailed history, as a clinician, we want to decide whether it is a treatable dementia or it's a degenerative dementia. So certain set of blood tests which we do for treatable dementias, like we check patients' vitamin B12, we check thyroid, we check blood count, sometimes severe anemia, vitamin B12 deficiency can cause memory problems. We also see for clinical examination where we check the fundus, where if there is any swelling in the brain, we get a brain scan done to look at any tumors or any infections in the brain, or a new disease which is encephalitis, which can present with rapidly progressive dementia. That is a dementia which progresses over months, associated with other neurological symptoms, memory issues, and behavioral issues. We also do a focused MRI focusing on the medial temporal lobes, because the medial temporal lobe and the hippocampus are the first areas which get shrunken in Alzheimer's disease, so might get shrunken. So clinically, we rely on the blood tests, the routine investigations, the autoimmune markers, like as I said, the blood test can detect a certain kind of autoimmune encephalitis called VGKC, NMDA, and paraneoplastic encephalitis. Then we get a brain imaging done to look for any space occupying lesions, any evidence of water accumulation in the brain, like normal pressure hydrocephalus, or any shrinkage of the brain, or to know whether there are multiple clots or multiple repeated strokes which have caused to, which has led to a vascular dementia. Another important aspect which actually comes before the tests is a neuropsychological assessment. So in the clinic, we may not get so much time to do a detailed neuropsychological assessment. So we go with a quick MMSE, which may take 5 minutes, or a MOCA assessment, which may take a little more time. So that's what clinical assessment, history, blood investigations, MRI, and in certain clinical cases, we might also do a EEG, that is an electroencephalogram, because patients who get repeated seizures, epileptic attacks called partial seizures or complex partial seizures, may present with memory problems instead of the typical history of seizures. And then other investigations are, of course, done for research purpose, the testing, the brain tests, and all that. Thank you.
Thank you, Dr. Advait, for explaining clearly about the number of tests that goes on before diagnosis. So it also shows how complex a diagnosis of Alzheimer's is, and that again takes me back to what Pratibha said, that we often tend to say, "I'm demented," very loosely people use, or you are demented, you're having these things. So we need to be very aware and understand the complexity of the diagnosis, because the symptoms are so overlapping. There's so many aspects of history and neuropsychology and the blood tests and everything coming together. I will definitely come to Pratibha a little bit later to talk about the neuropsychological assessments. I know that both Dr. Advait and Dr. Debanjan will have to leave at 7:30. So we'll take a few more questions with both of them first, and then we will probably move on to Dr. Raghavendra and Pratibha. And we also have a lot of questions coming from the audience. Dr. Advait, Dr. Debanjan, if you both could highlight a little bit about the treatment aspect, from both the neurological aspect and the psychiatric aspect. How do you plan the treatment? What are the different modes?
So when it comes to neurology, the treatment is limited. Of course, the treatment of the etiology, the cause, if the patient is having B12 deficiency or hypothyroid or some autoimmune disease like Hashimoto's thyroiditis, we need to detect and treat that. Then usually there are some medications like donepezil, memantine, which are anticholinergic medications which help to activate the brain cells and to certain extent might help in memory. There are some off-label drugs used in combination pills. So that we always tell the patient, this is not proven, but this might help you. So one pill of that and one for the donepezil memantine. So medication wise, there is, this is from neurology angle, and of course from psychiatric angle, if they have behavioral issues, Dr. Debanjan will discuss in detail. And along with the medications, I think most important is educating the patient how to take care of his daily routine. He should have a set routine where he does some or the other the whole day. And he is involved in all the activities. Yeah, can you hear me?
Yeah, now it's fine.
So along with setting a daily routine, educating the patient, educating the caregiver, and doing neurocognitive retraining is also very important.
Right. Thank you, Dr. Advait. Dr. Debanjan, would you like to add on to that?
Yeah, thanks, Advait. I think that's pretty much the medicines that we use. And so let me kind of just, in terms of management, besides what Advait said, let me just kind of divide into 4 parts. One, medicines to kind of slow down the progression of Alzheimer's. Number 2 is medicines to treat the behavior problems of Alzheimer's or any other dementia, and treatment of any other medical conditions which exist together with dementia. And finally, non-medical, whatever we can do. I think later Pratima may also add on to that. Now, in terms of medicines, I think it's very important when we are treating to convey to the family what exactly are we treating. Because as I mentioned, even though medicines exist, as Advait was mentioning, donepezil, memantine, we have other series of this class of medicines. We have rivastigmine, we have galantamine. These medicines are not magic drugs. It's not that you give the medicines and after 3 months the person has, the person remembers everything. Because the basic psychology of somebody coming and asking a pill from you is to expect that that pill is going to solve the problem. So it's very important what we convey to the family. And as I said, if the family comes back, many times there is a dropout because people think that doctor has given, and this happens, when I go to my community practice, sometimes you do not even have a CT scan. You do not even have the basic amenities to do a blood test. So you have to rely wholly on your communication and your clinical diagnosis. So many times people will simply not come back telling, doctor said this is an illness of memory. He gave a medicine, but memory didn't improve. So we didn't go back. And this leads to unnecessary chain of tests, doctor shopping, going from here to there, waste of financial burden and a lot of stuff. The financial burden itself of dementia is huge. in a country like ours. So it's important we tell them that what can we expect? It's a progressive thing. It is ultimately going to progress. For some, it may be 3 years. So for some, it may be 10 years, 20 years, doesn't matter. With medicines, all that we can do is we can slow down the progression. How much? That is only a function of time. I can't tell you in advance. I can't predict future from before. Second, something which really gets better is this agitation, suspiciousness, apathy, wondering. But then here I should also mention that medicines form only a small part of treatment. It's very important to understand a person with dementia is not able to express. So let's say I'm having as simple a headache. I have bitten my tongue in sleep. I am having constipation. I am having an infection and pain in some part of my body. I'm having fever. Simple things which may not bother us may bother individuals who are living with dementia because they are not able to express. So all that comes out is the person may be agitated. The person may not be willing to take bath. The person is having fever, so a person is simply not cooperating. The person thinks that it is his office time. He has to go to office, so he's going out of the house. The point is, no matter how much antipsychotics you give, these things are not going to get solved if you do not change the situational context. Very commonly, we talk about this ABC analysis, what precedes the behavior, and the consequence of the behavior. So it is important that even in a busy practice, if we can spend 5 to 10 minutes with the caregiver and ask, okay, what are the top three problematic behaviors? Okay, the person is not taking bath, the person is yelling, the person is getting suspicious. Why does the person get suspicious? Probably because when there is no light. So put him in a room which is relatively lighter. I'm not telling all the problems will be solved by this. Sometimes medicines are definitely needed. But the problem is in dementia, we cannot over-medicate because that brings in thousands of other trouble. So it's very important to try and see that if the person is not able to remember, if the person is not able to navigate, where are the areas of the problem? Again, very common, especially in old age homes, the clothes are not proper. It sometimes amazes me to see that basic human dignity cannot be denied for anybody, irrespective of the medical condition. If I am not having my clothes right, I'm going to yell myself, forget another person who is living with dementia. So no point giving an antipsychotic to treat this behavior. You have to understand that privacy, confidentiality, respect, dignity, autonomy, these need to be exercised for individuals living with dementia as well. And staff needs to be trained in that. The other important things are nutrition, looking after their sleep, having enough social interaction digitally, or making sure the family members come to visit them. Treating the medical conditions. A person who is having Alzheimer's is not immune to diabetes and hypertension and the other problems that he or she is having. So if sugars rise, if pressure rises, there can be a further stroke. And no matter how much we discuss Alzheimer's, Advait will agree on me on this, that vascular dementia, something which happens due to strokes, is extremely common in our country. And most individuals with Alzheimer's also have a vascular component. So with every bit of increase in sugar, pressure, obesity, strokes, the person is just going to have more and more progression. And finally, there are certain forms of therapy which are non-medical. So we talk about the reminiscence therapy, sitting with the person, bringing back old memories, sorting through old photographs, mementos which the person have gone back to. There are things which are yet not very research-based and time-tested, like aromatherapy, validation therapy. Now there is a involvement with children, pets, robotics, but those are pretty more exotic stuff. The basic thing is you have to keep the person involved. Again, if somebody tells a person is of moderate dementia and I cannot keep him or her involved, that's not believable, because even when the person has every single thing that is going off, the person still lives inside. So as long as we can keep them involved to some extent, let's say 70% of things he or she is not able to do, but at least the person gets happy when the person sits in the garden. When the grandchild comes, the person is happy. When there is a music, the person is enjoying. do not deprive the person of these benefits. And particularly there are things like occupational therapy, physiotherapy. It's important to look after the environment. A simple thing, somebody may not have a very slippery surface of the bathroom. So a person who is already having problems with navigation may kind of just fall down. Somebody doesn't understand where to go to urinate. So put big directions on the rooms to show whether the person is able to navigate or not. Have adequate lighting. 3 important resources. People can refer to the World Health Organization Eye Support Manual, which is freely available online. It's a wonderful resource. It's like a small workbook which helps the caregivers. Second, please go through the Alzheimer's Related Disorders Society of India, the ARTC and the ADI resources, the Alzheimer's Disease International, again freely available. And a brilliant resource is dementiacarenotes.in, the website. In fact, caregivers teach us more than we have ever learned from textbooks. So when we have caregiver groups, people come out with unique and brilliant ideas, as to how to take care of people. I remember, sorry, Ananya, if I'm taking a little bit time, I remember that, person who always used to wander off and no medicines could bring him back. What his wife eventually started doing is telling him that, we are going on a date, and taking him round the house some 3 or 4 times, then giving him some good food and bringing him back. It worked. This will not be written in any book of psychiatry or neurology. It's a very tailor-made thing that people come out with. So Dementia Care Notes exactly gives these narratives right from the life of caregivers. And I think, who knows, I actually speak in capacity of also a caregiver, because my granddad, who passed away now, suffered from Alzheimer's for a number of years in his life. And I was not even trained in psychiatry back then. But I do remember that, you learn best from others. You learn best with experience. And I think it's important in such a forum, or when we deal with our patients, that we spend time with caregivers, not only to train them, but also to learn from them. I know I spoke a lot, so I'll put an end here. Sorry.
And I think we would have loved to hear you for even longer had you not had to go. I think you have another program in 5 minutes, so I will not hold you back, but it was some really, really important points that you highlighted, particularly how much we can learn from caregivers. Sometimes we tend to only focus on, okay, what needs to be done, but that doesn't work that way. There's so much that if we can really understand the experience of the patient with dementia, what exactly is going on in his mind and what is his difficulty, I think we will be able to create a much better space, both environmental, like physical environment and emotional environment for him. And even that will help the caregivers manage the situation better. So it's helpful in both ways. So we just have 4 minutes left with Dr. Advait and Dr. Debanjan. Any parting comments or anything, how we as professionals and non-professionals, all of us, I think, can contribute to make this, make a more friendlier ecosystem for management and addressing Alzheimer's. So any parting comment, Dr. Debanjan, Dr. Advait? Dr. Advait, would you like to go first?
I think I will choose to stay back for a while, so Dr. Debanjan can speak.
Okay.
Yeah, so I think firstly, thanks Batul once again. Thanks Clarnet. Thanks Ananya, Advait, Pratibha, Raghvendra for joining me on this. And it's a very it's a very important thing that we take this narrative beyond a day, beyond a month, to continue discussing about it. Well, 1st October is the United Nations Day, International Day for Older Persons. And the theme this time is resilience of older women. And I specially mentioned this because some days back, for the same theme, we had a specific program on Alzheimer's in women. So I should, stress on the fact before leaving that there exists a lot of gender-based differences. As much as all the other differences that exist, women are more prone to develop Alzheimer's due to different reasons altogether. The progression of Alzheimer's is faster in them. And the caregiver burden is also more in them. In fact, more than 70% of caregivers in India, based on the dementia report again, are either wives, daughter-in-laws, or daughters of, patients. So when the role transition happens for somebody who has always been looked at the classic manager, to the point where that person needs care, I think there is an immense change in family dynamics. And we should remember here that the needs for male and female individuals living with dementia and male and female caregivers are very, very different. And that is both for home caregivers and paid caregivers. So I think, keeping in mind, you can continue discussion with the gender differences. I think it's a very relevant area to focus on. Finally, we briefly touched upon stigma related to Alzheimer's disease, but probably stigma exists more in us. It exists more in general, the medical professionals, non-medical professionals, because somewhere we are all afraid of aging. Aging is equated with something negative, something dark, something ugly, something which is not good and not looked up to. So the moment we feel that there will be a decline in memory, we kind of step back, stay back, and try to neglect it. When I speak today, I also speak in capacity of the co-chair, the Advocacy and Public Awareness Committee of the International Psychogeriatric Association. And I think we have always advocated for this. This is the United Nations Decade of Healthy Aging, 2021 to 2030. So when we talk about healthy aging, we talk about creating an age-friendly environment. Ageism needs to end. And all of us are responsible for that. It's a collective responsibility. Everybody listening out here, all the panelists, even if we can go and make one person aware that, dementia is not just a function of age. Alzheimer's is not just a function of age. The person stays alive. The person stays very much with us, irrespective of the medical condition. So if you do suspect any person having problems with memory, please get medical attention at the earliest. If we all take a step forward, probably, and that will be the success of this panel discussion, I think we can end the stigma for Alzheimer's, and hopefully the numbers, the untreated numbers, will not be that alarming. So that will be my parting comments and best wishes for the continuation of this discussion. I'd love to stay back, but we just have another Indian Psychiatric Society program, so I'll take your leave here. Thanks, Batul. And if anybody has any questions for me, Ananya, you can please share my mail ID, and I'd love to answer them later on.
Sure. Thank you. Thank you, Dr. Debanjan, for joining the panel. We at Therapy and ClearNet, we are very grateful that we could have you. And we hope to have this conversation ongoing. Like you said, that this narrative should not be only limited to one day. So let's hope for future collaborations, and all the best for your next panel.
Thank you. Bye, all the best. See you. Bye. Take care. Bye-bye. All the best, and greetings to the audience as well. Bye-bye.
Bye, Debanjan.
Dr. Advait, would you like to share any parting comment? Or you need to leave now, right?
I'll be here, yeah.
Oh, great. Lovely. Okay. Thanks a lot. Thanks a lot. Okay, so of course, we would have loved to have Dr. Debanjan also, but he had to leave. But we'll continue the discussion. We have a lot of questions coming up. So some of the things that he started talking about, I think we'll take up from there. One is this gender difference in terms of diagnosis. So Dr. Advait, how do you also see this gender differences in your patient population?
Not really, being a private practitioner, but the literature says that it is slightly more common in women because of various hormonal factors. But in my practice, we don't see much of the difference.
Okay. Dr. Advait, you also mentioned about neuropsychological assessment a while back, and Dr. Debanjan also highlighted how we can, when we are addressing, it's not only about neuropsychological assessment, but in treatment also, it has to be from all aspects. So my question is now from Pratibha, if you can tell us a little bit about the assessment and management of patients with Alzheimer's from a neuropsychological perspective?
Okay. Also, before that, I would like to comment on the gender difference. The
Yes.
literature suggests that it is like women are more prone to it. In my experience or limited clinical exposure that I've had, I feel that it's also a function of the place of a woman in India in a family dynamic, education, plus her role, because men generally are the breadwinner, and when they start showing cognitive decline, it's very evident. But when a grandmother starts putting more salt in the
Good.
curry, and those kind of smaller things, it's like, okay, now there is a daughter-in-law, or maybe there is somebody else who will take over that role. And because it's also about the social dynamic, like the woman will not be going out and socializing as much in a more responsible way. In that sense, she will have maybe her own circle, or maybe own relatives or friends, but nothing that is actually impacting anyone. And I think that is a reason that it doesn't only stand true for dementia or Alzheimer's per se, but a lot of other things also, depression or any other psychiatric illnesses, and that kind of, it's more of treatment seeking behavior rather than the incidence or prevalence of it. It's what I feel.
I think that's a wonderful point that you brought up, Pratibha. If we can hold on the discussion on the assessment and management a little bit and stay on this, because this is so important. When we are in a country like India, there are multiple socio-cultural factors that impact many things. And here, it's probably not just being a female biologically that determines whether you will develop Alzheimer's, but it is more about being a female in a country like India, where there are gendered roles and there are many things which are specifically different. That might also differ. Dr. Raghavendra, would you like to shed some light on the sociocultural aspect of both the prevalence of Alzheimer's disease and also in terms of, in diagnosis, early identification?
Yes, one moment. See, social cultural aspect, again, there are several factors to it. The prevalence, the help-seeking behavior, being the breadwinner, men are forced to seek help sooner, and being the women run the family in the background usually, so they don't and usually what happens is women, at least the women of the previous generation, most of them, they tend to put the family first, so they tend to ignore their own needs, they tend to ignore their own health concerns. That is what I see several families. So there are some biases which might happen, and I would love to hear from Devanjan on this thing also. But I feel there is a male preponderance in this issue, but I don't know whether it's a selection bias or it's a bias inherent in the illness itself.
Right.
Yeah, in addition to that, but again, see, cerebrovascular and other degenerative illnesses, by nature, women are a bit more protected, going by the medical point of view. And I'm sure Dr. Advait will agree to that. Yeah, so all in all, women tend to be a bit more protected because of their genetic and hormonal makeup. They have less of neurodegenerative vascular issues. They have less of collagen vascular issues, certain other issues. And men are more prone to hypertension, myocardial infarction, or other issues, which are in turn predisposing to dementia.
Okay.
So the bottom line is there is a in toto there is a male predisposition is what I feel, and literature also I feel there is a male predisposition.
Okay. Okay. So I think what we are seeing here, the literature, and here, if I may ask, the literature that you're referring to, is it like Western literature or Indian literature also suggests the same?
Western, I cannot offhand cite Western literature, but more of a Indian literature and Indian experience, I would say,
Okay.
with what I have seen at Nimans majorly.
Okay.
Nimans and elsewhere in other places where I've worked.
Okay.
But my private practice experience has been limited only to children and adolescents, so I would not be able to draw from my private practice experience.
Right. Okay. Okay. So I think we have some very important aspects here. Like one aspect is what Pratibha is bringing in terms of how sometimes the symptoms, particularly the early identifying symptoms, they get to be overlooked because, like for a man who is like if he's the bread earning member, he's going out and he will notice, okay, I'm forgetting these things, I'm not remembering, I'm not writing the files properly. But for a woman, things are like, and for a woman, what we mean by women who are particularly associated with household chores, and like it always comes up in something that I'm forgetting to keep something somewhere, or I'm maybe putting something else somewhere. So the presentation differs significantly, and there are some aspects of social cultural ways of looking at it. Now, coming to where we were with Pratibha in terms of the management part, it's both diagnostic and management. We know that neuropsychological assessments and intervention have an important role to play. So, Pratibha, can you tell us a little bit about that?
Yeah, so like I think Dr. Advait also mentioned, and when a patient comes in with probably in earlier stages with memory complaints and with issues in concentration, I'm not able to focus, I forget some small thing, I've just somebody has just told me, and I go to the other room and I forget about it, and those kind of things. So where we suspect, okay, there is some given the age, maybe if they are above 50 and above 60, that we look at maybe cognitive decline. And before all of these assessments of brain imaging and these are done more clinically, when you see these kind of symptoms, we start with smaller assessment, like I think Dr. Debanjan was or Dr. Advait was mentioning, I'm not sure, that we do an MSE or MMSE, or we do a MOCA, we do a ACE, that is Addenbrooke's. So those are more of screening tools, and that gives us some direction in so as to what is maybe happening, what are the problem areas, what are more conserved areas. Also, given a cognitive reserve is a big uh, contributor to it's a protective factor, not a preventive factor, but it's a protective factor, that if you have had education and you've been working for maybe 60 years, as opposed to maybe a farmer or maybe a skilled worker, rather than somebody doing more of other desk jobs and other things. So it also it is also based on that. Maybe if there is a slight impairment that you see in a farmer, or as opposed to maybe a manager in a bank or something, so the interpretation of both of these things are different. So the person who has had so much of maybe education and so much of using higher order functioning in day-to-day life, and that slight impairment is also a bigger issue for him. So that kind of interpretation difference is also there, because given the tests are, anyone can do that, but how do you interpret it, it is where all the difference also lies. after assessment coming to retraining, more of actually rehabilitation. And like I think everybody discussed, that there is only a limited scope for medication, neurological or psychiatric. It's more of management. There is, of course, no cure. So there is only a limited also scope, as well as what we can give, because um, there can be other issues in giving medicine for each and everything. So a lot of these issues have to also be um, resolved through non-medical interventions. So coming to Alzheimer's, especially, or dementia, there are some um types of interventions. So one is behavioral, that is that you work with the caregiver, and then like Dr. Debanjan was saying, ABC, the antecedent and the problem behavior and what is the consequence. You analyze, there is a behavioral analysis that we do, and then we try to modify the problematic behaviors. There's also that we have to look at if there is any physical, like he was saying, that they may not be able to express, maybe the language function is impaired, or maybe the expression is impaired. So there maybe they have a UTI because maybe they are not taking bath for a long time, and they are not able to take care of their hygiene, and these kind of smaller issues that may look like a hygiene issue, but they may also be taking up medical issues, and there may be uh, those kind of pains and irritations in the body or something that they are not able to express. So the management starts from there, that you first see what are the medical issues, and then investigate about that, and then you create a plan that, okay, this is how we are addressing it. And once that medical issue is resolved, probably the behavioral issues or the agitation will come down, or the aggression will come down. And then you see that, okay, taken care of all of your medical and physiological needs, what is left? And then we work on those things also. So in more advanced stages, then there, like he was saying about reminiscent therapy, that because there are memory issues, people with Alzheimer's start forgetting people's names, their faces, who is who, the orientation maybe. You and there is validation therapy. There is which are of course not as evidence based, but they are nonetheless working. And supportive therapy that we usually do, that okay, we are here to listen to you, we are not here to, you know, where did I forget that? Then you do not go and tell the patient that, okay, you have not forgotten, or you had not kept it here, you have Alzheimer's and you could not remember things. That is invalidating their experience. For the person at that moment, their experience is irritation or frustration with not being able to find something. And that is all we have to do, that be there for them, hear them out, support them, validate their emotion. And once they feel heard, they will also be more willing, because it's a push and pull game. How much you are going to push, they are going to, you know, it's like that. So once they also feel heard, they will also be more cooperative. And then you can make these things contingent also with your maybe cognitive retraining. You are giving them some cognitive enhancement tasks or memory enhancement tasks. So there are a lot of cognitive retraining and other modules. But how do you get them done is a bigger question, rather than, you know, having theory and modules over modules. So you can make it contingent, that okay, now I heard you, now we heard your we watched a movie, or we heard your favorite song, or we went for a walk you wanted to go for, or whatever you wanted to do. Now let's sit and do this for 10 minutes. So my point is that there are a lot of modules, but how you approach that and how systematic it is, and like it was being discussed, it is not you went to a doctor, you got a pill, and it's all sorted. It is not going to be like that. It is going to be it is going to be a process. It's a slow process, and it's more often than not a declining process. But you have to keep keep the management dynamic. Otherwise, talking about, there are stimulation-based interventions, there are emotion-based interventions, there are cognitive interventions. So there are different kinds of different perspectives that you can take, because Alzheimer's affect the person as a whole. It takes their memory, it takes their cognition, it takes their personality, it takes their emotion, how they feel and how they perceive the world, and what do they understand and what they make of it. So there's a lot of work that can be done with them. And there's also a lot of work that can be done with the caregiver, even the staff, that's training the trainers, but or the caregivers. But there's a lot that can be doing.
Yeah, I can also already see that there's a lot, and there's still a lot that you can probably talk about what can be done. So that is very hopeful to hear, and also makes us see again that it is not an isolated disease or a person who just has it and it's like hopeless and nothing can be done. There's a lot can be done, and more of it is from a very holistic perspective. So there, like we have Dr. Advait talked about the like medicinal treatment. Dr. Debanjan talked about many other aspects of the treatment, and Pratibha, you highlighted some of the very important aspects of management and how it is a very, like you said, the push and pull thing. It's more about understanding the pulse of the patient and sort of then see what is best for him, how to get him or her, be more engaged with the management process. And while assessments and these techniques are there, it is more about, at least as a psychologist, I think I can speak for that. It's more about creating that alliance with the client and the client's caregiver and sort of understand what's exactly going on, and then accordingly devise a management plan. So thank you, Pratibha, for giving a very detailed description of the management. One other thing that Dr. Debanjan highlighted, and I think this is something we all know, but again, that's not something we always talk about, is how in general people with dementia are treated in homes, in institution, like homes in the sense like institutionalized homes. And in general, how are people treated? Like he was talking about the dress, and there's so many things that, it's about how you talk, it's about what kind of food you give, the environment that you create. Dr. Raghavendra, you had worked extensively with, you're very knowledgeable about the legal aspects of, laws and ethics in India. And if you could shed some light of, what are the rights that a person with dementia, I'm talking about dementia here, like Alzheimer's, just one part of it. Are there any rights for people with dementia, particularly Alzheimer's, and what does the Mental Health Act of 2017, what does it state?
See, first thing, Mental Health Care Act does not specifically talk about dementia as such. It talks about any mental illness. So it can broadly classified. We can include dementia also, and there are certain laws which have been brought in by the government, which now also include like abusing elderly. The government can seize the property of the children who are abusing elderly. So there are several rules which are being brought in, and and you're not supposed to shun away the elderly. So there are certain rules which are being brought in, and in India the system is not that watertight. So there are some times where the children are shunning parents away, but it's not. But it's a bit. The family values are a bit stronger in India. The bond is a bit stronger, as we notice. There might be some exceptions. There might be some fights, whatever. There might be some issues, but nonetheless, the bond is still a bit stronger. And I'm sure you will agree. Being a psychologist, you would be seeing several families, right? And even I see, like I'm a family psychiatrist as well, so I see several families. No matter, there might be several issues, but they still go along. And having said that, the rights of the people with dementia, right to treatment, right to dignity, right to care, right to equal, right to respect, and right to equality. All those things are to be treated, and it's also enshrined in Constitution. uh, these things, all those things flow from the right to equality, which is enshrined in the Constitution. Article 14, I'm sorry, I cannot recollect the exact article, but so based, and it's unfortunate that we have to enact separate laws to basically reiterate the same thing, because right to equality means it's in fine print again, it's the same thing. Person with illness, without mental illness, it's the same, right? So but again, so sometimes somewhere we tend to lose focus, and then we forget that people who don't have a voice can get ignored, and we tend to ignore them, and we tend to neglect them, and we tend to, sometimes they'll end up getting abused. And you might see in old age homes, there's a lot of people, I mean, especially now, and there is one set of people like young people, we call that empty nest. Yeah, I was searching for that term, empty nest. Willy-nilly, kids fly off to different countries or different cities, and parents kind of left alone to fend for themselves. And I myself have seen such families, um, my friends and my several relations, I've seen them. So in these kind of situations, it's a bit tough call, because legalities cannot, you cannot pull some fellow from USA, tell him that you are supposed to take care of your dad or your mom, right? You cannot tell that. It has to come from within, right? No matter whatever legal thing is, finally it has to come from within. There is something called morality, which is above legality, isn't it? So yeah, so legality apart, uh, morality also becomes important in society. So treating elderly is also very, treating elderly with respect. And see, the word vruddha in Sanskrita, vruddha means who is vruddhi. Vruddhi hona means who has enriched. So who is enriched with experience, enriched with knowledge, enriched with money. So only when somebody is enriched with money, kids will come to them, right? Otherwise, if they're not enriched with money, parents don't have property, they will shun them away, right? So yeah, so I'm being a bit circumstantial, but the point I'm making here is legalities. Yeah, there are several laws. There are several laws which talk about recently government made a law about the rights for Mental Health Care Act 2017, where the institutionalization of mentally ill people and the treatment for mentally ill, which talks about treating with dignity and advanced directives, how to treat, and a person who gets admitted can say what treatment he can be given or he should not be given. So there are several things which have been iterated, but all these things can be followed in spirit only when there is a moral angle to it, an ethical angle to it, which is understood from within. So we need that should be inculcated, like Devanjan pointed out, from early childhood days. So so that is what also should be um, inculcated. A value-based education should be also made a part of curriculum.
Right.
So,
Thank you, Dr. Raghavendra. I think what you're essentially trying to highlight is we should not need laws to protect elderly rights. It should be love, it should be care, it should be values, it shouldn't be laws. And luckily, we are not yet there where we have very specific laws for them. So, which also reflects in a way that we are taking care. Like, of course, there are incidents where things are not happening, but there is still hope, and there's a we still are being able to take care of our elderly population.
Yes.
And
Yeah.
Yeah.
Just wanted to
So-
add. I have some
Yes.
old age Sorry, I'll not take more than a minute. We are it's 7:58. Sorry. So I
Okay.
have a couple of friends who are old age psychiatrists in Australia, England, and so they tell that old age people are usually abandoned. They just are dropped off in front of a hospital without.
Mm.
They are put in a wheelchair and they're just dropped off,
Mm.
and then just nobody comes back to pick them up. So it's like that, but that happens far less frequently, far less frequently in India. Agreed. I mean, one might argue that they are kept back in home and they are abused also, but at least they are at least taken care of with some amount of respect and dignity, and they're not shunned on the streets. At least that is what I would want to highlight.
Right. Thank you. Thank you for highlighting that very important point. I know we are absolutely at the end of time. But we have a few questions. So if I may request the panelists to respond to the questions very quickly so that we can answer most of them. Dr. Sanjay Rothithor asks, are we seeing increase in number of cases in India since COVID times? Anyone would
Yes.
like to take?
Yes, we are seeing increased cases, and especially patients who had dementia after COVID, some of them have progressed rapidly.
Okay. Dr. Veena Tejan is asking, like these days we are coming across elderly cases of dementia 90 plus. We have to manage them aggressively with low dose mood stabilizers and antipsychotics. Please throw some light on the management of elderly dementia. She further, okay, this is her question. Please throw some light on the management of elderly
What
dementia.
I feel is in elderly dementia, we should always focus on not harming the patient, as we always want to give minimum medications, and just don't have a very unusual hi-fi expectations. Be very realistic, and let us make their life easier rather than expecting that, okay, they will jump or they will play chess with me.
Right. And communicating realistic expectations to the patient and the caregiver so that they also know what really can happen through this interaction with the dog. Because I think once they come to the doctor, they feel, okay, this is a magical place, but that's not. If it is degenerating, it is degenerating.
And I always encourage my patients to have a holistic view. And study of some basic principles of Ayurveda also helps in treating elderly patients with minimum medications and just the small lifestyle changes which we have been doing, which our grandmothers, grandfathers used to do, which are harmless, can be studied and taken up.
Right.
That is what I am always appreciative of Dr. Advait's approach. He tries to give a blend of everything, and he doesn't get carried away by this pathy, that pathy, or any pathy. He tries to give what is best for the patient and not for anything else. So that is what is, because we all are eventually for patients and not for anything else. That is how we should see, because finally patient should have a choice what he likes. That is what even I feel.
It's all about, beneficence and non-maleficence. That is like the pillar of, and I think client autonomy is so important. We just need to understand. I still remember times when the doctor would come and say, okay, this is what I'm prescribing, but now they explain. And at Nimhans, I remember we had to ensure that we are explaining, and we had to note it in the file that we are explaining everything. So that is excellent. Like at the end, whatever is beneficial for the client, and as long as it is not harmful to them, I think we should give our best. The last question is, can Alzheimer's be a reason for schizophrenia or vice versa? This is a question from Dr. Akshita Singh. Can Alzheimer's be a reason?
What I feel, only one line, that some patients of Alzheimer's can develop psychotic symptoms. So I'm not sure whether we can call it as schizophrenia, but they can develop psychotic symptoms like delusions, hallucinations. All that.
Yeah. But if, like, correct me if I'm wrong, are the hallucinations more like visual in nature when it is organic, and with schizophrenia it is more auditory? Do we see any kind of difference like that?
Yes, but I want Dr. Raghavendra to add on this.
It's multimodal, like Ananya pointed out. It is many times multimodal and visual and olfactory, and in schizophrenia, it's predominantly auditory. And like Advait pointed out, see, schizophrenia, again, see, in psychiatry, it's a symptom cluster, we take it up. So this symptom A, B, C, symptom X, Y, Z will add up together to form a symptom cluster. So schizophrenia, a person with schizophrenia can, after several years, might develop Alzheimer. There might or might not be a link to each other, right? Like somebody had diabetes, later on developed cancer. There may be a link, there may not be a link.
Got it.
So it's like that. And vice versa also. Somebody with cancer might develop a diabetes.
Right.
So it has to be taken in a case-to-case basis. But again, there is no specific causation to it. If you say medical science has not established any causation to it.
Right. All right. We have just come to the end. Any parting comments from each of the panelists, if we can get one line sort of a take back from today's session?
So I just want to say that we have to walk together, everyone, neurologists, psychiatrists, psychologists, even occupational therapists, physiotherapists, for the benefit of patient and for the complete rehabilitation. So thank you very much for arranging this discussion.
Thank you. Thank you, Dr. Advait.
Thank you very much, Ananya, for this wonderful panel and for organizing everything. And it was really a very good platform. And it was a very curious mixture, I would say. I was like somehow standing out like a child among adults, I would say.
But there is no child, there is no adult without a child, right? You want to understand an adult, you have to understand the child.
Yeah, that's true. That's a nice thing. You just swept me off my feet. Yeah.
Yeah.
Okay.
Thank you.
Yeah.
Thank you, Dr. Raghavendra.
Okay then. Thank you, Pratibha. Thank you, Batul.
Thank you, Ananya and ClearNet to give me this platform. And definitely, dementia and Alzheimer's it's a complicated cluster of symptoms, and it can be overlapping and it can be really confusing. In theory, it is still a little bit of you can understand, but in presentation and the nuances of management of it is something that's that was quite more than informational. It was motivational, that okay, that it's not something that to be scared of or to be confused about. It maybe you need to unravel it slowly and take one step at a time. So it was a great discussion, and thank you, everyone.
Thank you. I also would like to thank, on behalf of Therapy and ClearNet, I would like to thank all the panelists for their wonderful contributions. I think what my takeaway is, like, of course, we always say that every client is unique, and for every client, the management plan has to be unique. But what Dr. Advait said, we have to all come together. So let's understand each client's journey. And then let's see what is best for the client, and let's all come together, and we all can do our small bit. Like Dr. Debanjan was saying, that even if each of us, like there are around 3,000 people today, and if each of us can go out and talk about some of the things that we discussed, some of the myths that were busted, some of the actions that can be taken, I think that is also a big thing that we can do. But coming together as like in different fraternities, and everyone coming together and really focusing on the wellness of the client, that is, I think, the best takeaway. So thank you everyone from coming together, and thank you Batul for being so patiently being there, providing all kinds of all kind of back and support and arranging everything. Thanks for that.
Thank you.
Bye.
Thank you. Bye bye.
Bye bye.
Good night, everyone.
Night.
Good night. Good night.
Good night.